Hey everyone, welcome to This Explainer. If you're stepping into the world of medical coding and billing, you probably already know that Medicare is kind of the 800-pound gorilla in the room, right? But as a professional coder, you've also got to master the wildly complex web of non-Medicare government payers detailed in Chapter 6. So today, that's exactly what we're focusing on. We're going to map out the unique invoicing criteria and all those strict regulations that dictate how you actually get your providers paid when dealing with these other massive government entities. Let's dive in. So here's our roadmap for today. We'll start with a quick overview of other government payers, move on to the Affordable Care Act, break down Medicaid basics, look at eligibility and spend downs, cover Medicaid coding rules, and finally wrap things up with military and labor payers. Section 1. Other Government Payers Overview. Okay, so while Medicare is obviously the chief government payer for seniors and the disabled, it is really just one piece of the puzzle. Today, we're zooming in on the other three major entities. You've got Medicaid, which steps in for low-income individuals. Then there's TRICARE, serving our military members and their families. And finally, the Department of Labor, which manages care for injured government employees. Listen, if you treat these the same as standard commercial insurance, you're practically guaranteeing denied claims, because they each play by their own completely distinct rulebooks. Moving right along to Section 2, the Affordable Care Act. To actually bill properly in today's landscape, you have to understand the legislative foundation we're working under. As a billing professional, you really need to know the three core objectives of the massive 2010 Healthcare Reform Bill, which we all know as the ACA. This law fundamentally changed eligibility and funding across the board. First up, it aimed to expand affordable coverage by offering premium tax credits, basically subsidies that reduce prices, to households with incomes between 100% and 400% of the federal poverty level. Second, it made a huge push to increase Medicaid coverage for adults. And third, it aimed to heavily encourage cutting-edge, innovative medical care delivery strategies just to try and reduce overall healthcare expenditures. And here is a super important number for you to remember: 138%. The ACA's goal was to increase Medicaid coverage to include literally all adults with incomes below 138% of the federal poverty level. That vastly expanded the patient pool. However, quick side note, you've got to keep in mind that not all states actually adopted this expansion. So, depending on where you practice, eligibility can shift pretty dramatically. Section 3. Understanding Medicaid Basics. So Medicaid is a state-run program, but it's overseen by the federal CMS. Basically, the feds establish the requirements and the state actually implements them. Broadly speaking, it splits into two main categories. You have community Medicaid, which assists qualified beneficiaries who have little to no medical coverage. By contrast, you have nursing home Medicaid. This helps pay for residential care expenses, but, and this is unique, it requires recipients to contribute the vast majority of their own income toward the price of that care. And while federal law guarantees a baseline of care for both of these, states can absolutely offer supplemental services depending on their specific budgets. Section 4. Medicaid Eligibility and Spend Down. Now, eligibility isn't just about income. It is heavily tied to financial assets. So what happens if a patient is low income but has maybe just a few too many assets to qualify? Well, they enter what's called a spend down. These patients must literally spend their own personal assets on medical expenses, totally out of pocket, until their wealth drops to the exact point of eligibility. From a billing perspective, this is notoriously tricky because, honestly, you often can't even tell if a patient has a spend down until after the claim goes into review. Let's get into the nitty-gritty. Section 5. Medicaid coding rules. Okay, let's do a little scenario math here, because Medicaid operates very, very differently from other secondary payers. Imagine your patient has a primary commercial insurance contract that allows a $1,000 claim for a procedure. But the Medicaid fee schedule dictates that that identical procedure only pays $500. So when you submit this as a secondary claim over to Medicaid, what happens? Do they chip in to make up the difference? The answer is a hard no. Medicaid functions strictly on its own fee schedule as the payer of last resort. If Medicaid caps out at $500, they pay exactly $500, and boom, the matter is considered entirely resolved. Medicaid literally doesn't care what the primary insurer allows. They play strictly by their own numbers. And beyond fee schedules, you also have to investigate specific state billing standards. Since each state runs its own program, the modifier rules can be all over the place. Some carriers require very specific modifiers for certain procedures, whereas others just don't. And here's an even bigger challenge. Our source text notes that a lot of Medicaid payers still utilize really old claims processing methods. What does that actually mean for you? It means you might actually have to use retired modifiers just to get the claim processed. If you submit a claim with a brand new, totally valid modifier, but it hasn't been added to the payer's legacy processing software, it's going to be rejected. Always, always verify with the specific state payer before you submit. All right, home stretch, Section 6, Military and Labor Payers. Finally, you've got to master TRICARE in the Department of Labor. TRICARE is managed by the Department of Defense, and it has a few distinct plans. TRICARE Standard basically operates like a PPO. TRICARE Prime is your HMO-like plan for active duty, and TRICARE for Life serves as a Medicare supplement. You'll also encounter CMPUs, VA, which covers dependents and spouses of disabled or deceased veterans. And then you have the Office of Workers' Compensation Programs, or OWC, which manages labor claims. You really need to know their specific divisions, like FECA for federal employees, the Coal Mine Program, and the Energy Workers Program. Let me tell you, billing the Department of Labor is intense. It requires mandatory provider registration, insanely strict pre-authorizations, recognized diagnosis code limits, and mandatory electronic funds transfer. You absolutely cannot apply a one-size-fits-all approach here. So what's the ultimate takeaway here? Mastering government billing requires a level of precision way beyond just knowing Medicare. Whether you're trying to navigate a messy spend-down or fighting through strict pre-authorizations for the Department of Labor, your precision is literally the only thing standing between a provider getting paid and a massive, costly denial. Think about it. If your practice doesn't have a solid system for tracking all these wildly varying rules, how much revenue are you just leaving on the table? Please like, share, and subscribe to Decode Healthcare with Herschel.